Hello everyone, my name is Viknesharan Alakisasi Kumar, and today me and my friend Juan and Is are going to present a case study regarding hemolytic disease of newborn. What is hemolytic disease of newborn? Hemolytic disease of newborn is a clinical condition arises when a mother's immune system produces antibodies against the fetal red blood cells antigen that she lacks. While various blood group systems can be involved, but the RHHD event is notably severe because the D antigen is fully expressed on the fetal cells. When these maternal antibodies crosses the placenta, they destroy the baby's red blood cells, leading to dangerous complications such as severe anemia, jaundice, or even hydrocephalus. But in this case, it's very unique because it features the block RHD phenomenon. This happens when maternal antibodies levels are so high that they completely coat the baby's RHD antigen sites, causing the standard lab test to incorrectly identify the babies as RHD negative. Before I proceed to the laboratory finding, I would like to give a short intro regarding the patient history. Our patient presented in this case study is a 24 years old female at 38-week gestation. She is group O RHD negative, and crucially, she presented with a massive anti-D antibody titer of 12048, despite having no history of blood transfusion or any prior RHO gam injection. She delivered a male newborn via C-section, and the infant showed immediate signs of severe HDFN, which is severe anemia. His hemoglobin level was critically low at 1.56 milligram per deciliter, and also jaundice, and his total bilirubin was elevated at 52.7 micromole. Now, let's review the lab finding of this case study. While the mother was confirmed as phenotype DCCE, the newborn initial RHD status was uncertain due to inconsistent result. To resolve this, several confirmatory steps were taken. First, the direct anti-human globulin test, which was strongly positive as 4 plus, indicating the baby cells were heavily coated with antibodies. Next, an ILVA test, which was also strongly positive, specifically detecting the NTD. And the third one, we perform a heat elution test at 45 degrees Celsius to physically dislodge the blocking antibodies. Following this, the baby cells clearly reacted as RHD positive. Finally, the RHD genotyping also confirmed the presence of the RHD gene, definitely identifying the infant as RHD positive. Hence, these confirmed that the initial negative results were not due to the lack of the antigen, but rather the block D phenomenon. Now, I will pass to my friend One to further explain regarding the case study.
And now I will be presenting about the diagnosis, the pathogenesis, and the treatment for this case. Now, the diagnosis is a newborn from the mother suffering from HDFN, which is complicated by the block D phenomenon. The mother was an RHD negative with a very high NT titer. The newborn possessed anemia and elevated bilirubin. Uh, the test also has a strong positive on the direct antiglobulin test. This all suggests for HDFN, but the the diagnostic is not confirmed at the early stages because the testing for the RHD for the one was inconsistent. But finally, it was confirmed to be a HDFN, which is complicated by the block D phenomenon. Now, for the pathogenesis, how this happened. The maternal IgG NTD body cross the placenta and destroy the baby red blood cell by binding it, which cause hemolysis, which leads to anemia. All of this cause the HDFN cases, and at the same time, the D antigen of the newborn is blocked by the mother's IgG, which cause the lab diagnostic findings to be inconsistent because there's no reagent to bind it in the lab diagnostic test. For the treatment, the newborn is given blood transfusion. The blood transfusion that is given is specifically RHD negative. This is to remove uh, the negative blood which is coated by the maternal mother to prevent more hemolysis. Now, this also can prevent further immune destruction of the newborn, which is why the negative blood is used for the blood transfusion for the newborn.
Now, for the prognosis, the newborn developed hemolytic disease of fetus and newborn due to high titer maternal anti-D antibodies. The baby presented with anemia and elevated bilirubin levels and required exchange transfusion with RHD negative blood. With prompt treatment, bilirubin levels normalized, although the baby needed follow-up transfusion for recurrent anemia. Overall, the prognosis was good with early intervention. In the discussion, this case highlight the block D phenomenon. The high concentration of maternal anti-D antibodies coated the baby Rhd positive red cells, making the D antigen difficult to detect during routine testing. This caused inconsistent Rhd typing result. Heat elution and genotyping were performed to confirm the true Rhd positive status. In conclusion, block D phenomenon should be suspected when a newborn has anemia, hyperbilirubinemia, positive DAT, and weak or inconsistent Rhd typing, especially if the mother is Rhd negative with high anti-D titer. Early recognition and appropriate testing are essential to prevent misdiagnosis and ensure proper transfusion management.